So in the interest of sort of the fellowship boot camp, I want to ask you a couple questions from management. So you have a patient with a acute dissection and they present with organ malperfusion. So a classic debate is, do you do the ascending first and then do the reperfusion later? Do you try to do the stent grafting and then see if the reperfusion is done? And when would you do an open reperfusion for a visceral or for a leg?
So you were in Michigan, so you know the answer already. But essentially, the thought is you do the type A first. Obviously, that's what's going to kill you. And most of them actually don't require anything after that if you're able to tack up the dissection flap well in your ascending repair. Now, there are circumstances, and we have some patients, and I'm sure you've seen them and other people have seen them, is where you would like to actually probably stent graft early in the descending portion. And obviously leaves the arch sometimes dissected. That seems to not be much of a problem, but you can obviously get some dilation down the road. But essentially, you're trying to get the patient to survive. So type A has to come first, and most of the time, you don't need to do a revascularization for the viscera. Yeah.
Thanks. Appreciate it. All right. Any questions or anything else? We got a few minutes. Yes, sir. So the question is, do we use ROBOA for ruptured AAA? So for those of you that don't know what that is, that's a really interesting technology that was developed by a friend of mine. But basically the concept is in the field, particularly in the military and or in the field with blunt trauma, the majority of people that die exsanguinate. And historically, some of you may have done this, you'd open the chest and put a clamp in the thoracic aorta, you restore perfusion, they make it to the operating room, and then you save them doing something. So is there a way to do a percutaneous? Anybody with minimal training could stick a balloon in and occlude the thoracic aorta with a balloon rather than doing it the old-fashioned way with a knife. And most vascular surgeons will use a ROBOA phenomenon for ruptured aneurysms. If you have an unstable ruptured abdominal aortic aneurysm or even a thoracic aneurysm, you can, even under local, very quickly get in, get a sheath in, and put a balloon in above the rupture and then fix it below. So we do use the ROBOA phenomenon as vascular surgeons all the time. Specifically the ROBOA, which is sort of like a Breslow tape, all hands, simplified balloon placement is designed for trauma surgeons or ER doctors and for a sort of military on the field to get them. And it's actually really cool results in the military field where they've actually saved lives. Where I think they have like 5 or 6 documented cases where they got a ROBOA, got definitive care and survived. So I don't know if that answers your question. If someone's unstable and hypotensive, we do that. We use our aortic balloons as the aortic clamp. And some people even advocate, even if you're planning on doing it open, it's physiologically safer to put a balloon in first, open them, rather than open them, decompress the abdomen, then kerfuffle trying to get control of the aorta. So if they're really, really unstable, a balloon will definitely save a life. Any other thoughts? Okay, Dr. Lumsden, let's break. Thank you.